6 years ago, there was an outbreak of a certain virus, COVID-19, which really hit the world and shook the world. And there has been a lot of controversy surrounding its origin. Where do you think the truth is coming from? Which side is more closer to the truth?
I think for now the wet market seems to be more plausible, but we should also be very open-minded.
Scrolling through social media, you end up seeing a lot of controversial videos. One of them is Bill Gates coming up and saying, in the next few years, you're going to notice a bioengineered weapon that will finish a huge population on this earth. And the whole world collapsed into COVID-19. Did he know something that we did not?
It will be very far-fetched because, bioengineering has been there for centuries. For example, some of these assassinations that were undertaken through, for example, inhaling anthrax spores, that was actually as a consequence of bioengineering.
Why do you think the investigation was kind of impaired by the Chinese government?
That would be a very good question for them, to be honest. That would be a very, very good question for them.
From your experience, what was the time frame between an active infection and a death that you saw that actually spooked you at that time?
I can tell you every COVID case spooked me because for me, most of the cases that I used to treat were intensive care, intensive care, high dependency, so more or less critical care, so to speak. And I can say if a patient came to HD or ICU, more often than not, because I think for us, from my own estimate, our case fatality ratio was just about 13 to 15%. For us, we were literally learning as we moved because things were not clear at all.
Do you think that COVID-19 was the least of the worst that we should expect?
Definitely, we've not had the last of pandemics.
Beautiful people, welcome to the Laughing Lab Coat. Today's conversation is about understanding the controversy versus the facts behind COVID-19 as it happened a couple of years back. Today, our special guest is with Dr. Paul Yonga, a well-renowned specialist in the field of infectious disease and epidemiology. Daktari, karibu.
Asante sana. Thanks for having me.
Thank you. And just a quick background. Off the camera, I asked you what inspired you to go into infectious disease, considering it's not a field many doctors are rushing into, like in the sense of surgery or things like that. What was the inspiration?
To be very honest, even up to now, most people still are not very enthusiastic about diving into infectious disease. I think some people joke that it's not very lucrative as opposed to what we call your procedural specialties, like for example your surgery, obstetrics, whereby you get paid per procedure. Infectious disease is more of what we call a cognitive specialty, whereby you manage patients by thinking through their problems and trying to come up with a diagnostic pathway and eventually coming up with a solution for their problems. Normally, most hospitals will not pay you to think about some of those problems. You go into a procedure and you're paid, but for infectious disease, that doesn't happen as frequently. But over time, we are now starting to train infectious disease physicians to start doing quite a few procedures which can augment, their economic
status
the economic
part
status.
Of the training as
exactly, yeah. And also, secondly, we also want it to be in such a way that they are paid for their thinking. So, a number of countries, their healthcare systems are trying to think through how some of these cognitive specialties like infectious disease, geriatric medicine, oncology, how they are paid to think through the diagnostic pathway of patients. So more or less, that's why I think most people are not going into that. And then also there's a lot of reading involved.
True, true.
Yeah.
And narrowing down to the main conversation that we're going to have today, about 6 years ago, there was an outbreak of a certain virus, COVID-19, which really hit the world and shook the world. And there has been a lot of controversy surrounding its origin. There are those that initially, when the reports were coming out, you'd see people say there was a wet market somewhere in China that was the start point of this pandemic. And now you can see several news agencies, big ones, including the US, saying that there was a lab leak somewhere. Where do you think the truth is coming from? Which side is more closer to the truth?
To be very honest, with some of those controversies that came in, it now became more unclear where exactly this outbreak began from. Because you can remember for the first year, if I can be honest, for the first year, we were heavily reliant that the pandemic really started from a wet market. And in fact, they actually say that it jumped into a certain host before it came to humans, especially through consumption of the meat of that particular host. I think it was a pangolin, if I can remember. And that is what we knew for the first year. And then when the United States now started raising some of these concerns that probably there could have been a lab leak, specifically from the Wuhan Virology Institute, if I can remember, I think that's where investigations started venturing to. I think the biggest problem is that the lack of transparency that started taking place during the lab leak investigation. Because you can remember when that process started, I think there's a team from WHO that was sent to Wuhan. But I don't think they were given enough space to really do their work.
Okay.
Yeah, because there was a lot of, they were being guarded. They would be taken in cars. They would not even, the identity would not be revealed.
Yeah.
There was a lot of information censoring.
Yeah.
So that lack of transparency is what really is driving this other second theory. But generally, to be very honest, that lack of transparency, when you're not transparent in anything, it drives a lot of,
fuels.
It fuels a lot of theories.
Yeah.
It may or may not be a conspiracy theory, but the minute you're not transparent, it already shows that there's something that is not being people are not being forthright with something. Yeah. But I think for now the wet market seems to be more plausible. But we should also be very open-minded that these other the jury is still out on that for sure.
Well, if someone was to ask, let's say the wet market used to exist even before.
Yeah.
Right? How come that these events or such kind of infectious disease processes that would, let's say, locally affect an area, how come it has it happened before from the same wet market in the sense such that it can support now this other theory or thing that happened with COVID-19?
Well, a lot of viral infections have really come from, even when you speak about Ebola itself. Ebola is more or less it may be thought of indirectly, but it's actually from a wet market because people you find people eating a lot of meat, I can say our siblings more or less, the monkeys and the like. It's actually from a wet market, but those ones are more of the viral hemorrhagic fevers. But when you talk about the respiratory viruses, ideally, that's why I was actually saying that there's really a lot of lack of transparency in how these things emanated. Because when you see even some of the index cases, it's not very clear where the first index case actually came from. But as they always say, when you hear one story, people stick to that story and they run with it. But you see, there are those two theories that so far have really come out clearly. I would not be surprised if someone came up with a third or fourth or fifth theory, to be honest, because of that, just that lack of transparency. But I think the one that has been said so far is really the wet market. But I completely agree with you that not many outbreaks, particularly of respiratory viruses, have emanated from wet markets. Yeah.
Okay. And just again, scrolling through social media, you end up seeing a lot of controversial videos. One of them is Bill Gates coming up and saying, in the next few years, you're going to notice a bioengineered weapon that will finish a huge population on this earth. And he went further and said, majority of these deaths will be occurring in places such as Africa. And this was like 2-3 years or a couple of months before the whole world collapsed into COVID-19. Some people definitely will think, this guy said this, and this happened. Did he know something that we did not? Do you think there's a link there?
To be honest, that will be, I don't know, it will be very far-fetched because, bioengineering has been there for centuries. For example, some of these assassinations that were undertaken through, for example, inhaling anthrax spores, that was actually as a consequence of bioengineering. Where if someone wanted to assassinate you, they would bioengineer some of those anthrax spores, put them in an envelope, send them by post, you get a post inhale, and you're more or less gone. So that is something that really has been there for
quite some time
quite some time now. And I do not know the linkages between Bill Gates and China, because the problem, the burden really started in China. The cases were really the biggest burden was noted in China.
Okay.
And then from there really spread out throughout. So I probably may not read so much into it. Maybe with time we'll see exactly what people mean. But I think specifically for COVID-19, I don't seem to see that clear linkage. And as I said, this lack of transparency is really bringing a lot of confusion. Because even I myself, right now, if the WHO investigators would have been given the space and really investigated and found out what exactly happened, then probably would.
Why do you think the investigation was kind of impaired by the Chinese government?
That would be a very good question for them, to be honest. That would be a very, very good question for them, because if you have nothing to hide, it will be clear for some of these. And I know, and I mean, genuinely speaking, when it comes to pandemics, to some extent, I would also understand them because, sometimes when you see an outbreak happening in your own country, there seems to be some sense of stigmatization. So you might even be really innocent.
Yeah.
But you're in an era of where there's a lot of global geopolitics where certain countries are stigmatized.
Yeah.
Even that country might fear to come out openly.
Yeah.
To give out. They might really be innocent, but when the transparency comes out, then now people will sneak in their own ideologies. So to some extent, I understand them, but nevertheless, it would have been nice if they are transparent. Because one of the things I do pride them for is that when the pandemic started, they shared the sequence in good time. They actually shared the sequence of the virus in good time. So that level of transparency, yes, was really appreciated. But I think for these others, they could be having their reasons. So that's why some of us would not really be in a hurry to vilify them for not being open.
We saw significant numbers being mentioned across nationwide platforms, media coverage centers. How true are those numbers?
Personally, I feel, particularly for Africa, there was definitely a very gross underestimation of the numbers. And for Africa, it's because of it's fairly multifactorial. Remember when the pandemic started, we didn't even have testing facilities locally.
Yeah.
Most of our samples were being shipped to either Johannesburg or Dakar. So chances are in between. And I remember it was, I think, until about a month before we started developing local testing capacity. So definitely in between, I'm sure there are a few cases which may have been
Not
missed,
documented.
which were missed in the process. In a lot of the Western world, I know they really did their best to capture as many cases as possible, to test as many people as possible. A lot of those cases were ending up in hospital, but of course, because also of the straining of the healthcare systems, some of those cases died while undocumented. So for me, I would not see it of more of an overestimation, but more of an underestimation. Because in the Western world, some cases went untested because some of those cases did not make it to healthcare facilities because those healthcare facilities were already strained in the process that they could not accept any additional patients to come into their system. Whereas for some of us in Africa and the other developing systems, the testing capacity was not yet fully developed. And then the second thing is that even if the testing capacity was there, I mean, testing was very expensive.
Data
I think,
collection,
accuracy. Testing, I think, when it started, I think the cheapest was about 20,000 when it was just starting. Before it started, slowly dropped down to about 6,000 to 7,000. But the first 2 months, it was about 20 to 25,000 at the very cheapest.
So there's a lot we missed during that time.
Definitely there are a lot of cases we missed. And then remember also, if you got unwell, most of those cases were not going to hospital because number one, insurance will not cover you if you got unwell. And then secondly, of course, just because of the nature of our healthcare system, most of those cases will not end up in hospital. So personally, I feel there was a very gross underestimation of the number of cases that we had.
Coming from a clinical perspective and during that time, being a specialist in that field, I'm sure you're coming across a number of cases of patients who are actually having COVID. From your experience, what was the time frame between an active infection and a death that you saw that actually spooked you at that time?
I can tell you every COVID case spooked me because for me, most of the cases that I used to treat were intensive care. Intensive care, high dependency, so more or less critical care, so to speak. And I can say we could probably, if a patient walked in into ICU, and I'll be very specific, if a patient came to HDO ICU, more often than not, because I think for us, from my own estimate, our case fatality ratio was just about 13 to 15%, which is still
slightly high.
Quite high, yeah, because most of those patients were very sick. And at that time, most of those medications were not readily available. Because initially, my first, and I'll give you a very personal experience. My first case was actually in Mombasa. I remember I was at home, I was asleep. Then I get a call at 3 a.m. in the morning while I'm asleep here in Nairobi, being told that we have this patient. This patient is hospitalized in Mombasa. Is it possible for you to come to Mombasa? I remember that time there were curfews, there were roadblocks. So I was like, there's no way I can drive to Mombasa with all this. Then they were like, no, don't worry. Just tell us you're available and we'll find a way.
Okay.
Yeah. And they actually found a way. So I actually went by air to Mombasa. And I see this patient who was very sick. And at that time, unfortunately, the diagnosis was not very clear. Are we dealing with influenza? Are we dealing with COVID? Because both tests came back positive.
Positive, yeah.
Yeah. So that was the time when we still were not clear whether steroids could help in management. Because normally for influenza, we don't give steroids because they tend to worsen the situation. So for this patient, we were not clear, but we actually gave steroids. And somehow the patient
Started responding to
survived.
them.
Yeah. And then 2-3 weeks later, after we've treated that patient, is when the results from the recovery trial were coming out, which actually showed that using
Steroids.
dexamethasone can actually
Help with managing.
can actually help in that entire situation. So it was a very interesting, so for us, we were literally learning as we moved because things were not clear at all. But as we started moving, it started becoming clear that there are other supportive things that we needed to do for these patients, because these patients were clotting a lot. They were clotting. They were literally clotting in every single blood vessel. So you needed to control some of those, and some of those drugs are not cheap.
Yeah.
So in addition to giving your dexamethasone, there are these other additional things that you have to give, in addition to the oxygen, in addition to now when you start intubating these patients. So it was a very chaotic way of managing patients. So you find even the guidelines were changing as we kept moving. But by and large, by the time patients will come, some patients will die probably even in day 3 of admission. So some patients will find that by the time they're coming, they're probably unwell for like 2 weeks at home. Then they're coming in, then
quite a critical stage.
Exactly. By the time they're coming in, their lungs are pretty much battered out. And then there are some who would come in and battle it out. They're in ICU for maybe like a week, 2, they survive. Then the others who are there for like a week or 2, they're clotting all over the place. Others are forming plugs within their airways. And that time you could not even do bronchoscopies at that time, because most of our ICUs are not filtrated enough for you to do such procedures.
So it would put you at risk.
Exactly, yeah. So you find some of those patients we lose them because of that. So the timing really differed. Some would 3 days, others 14 days, but at least the majority will try to get them out of it.
Interesting. Moving on from the active infection to now this conversation that spins natural immunity versus vaccination. Was there a need to vaccinate individuals who actually had the natural immunity to the virus?
So there are 2 aspects to it. Number one, unfortunately, there are no validated ways of measuring natural immunity. It's not like infections like measles, where you can actually measure. If you are infected, you can actually build natural immunity and actually measure. And for those people who have immunity, then you can avoid vaccinating them. Same to things like varicella, chickenpox. Yeah, those ones you can easily quantify natural immunity. For some of these respiratory viruses, it's a bit shaky. You can't really measure natural immunity. So it becomes difficult for you to make a decision of vaccination based on that parameter. That was the first thing. And then the second thing was the excessively high numbers of mortality that were coming out. You can't wait for someone to get infected. When you see people dying the way they were dying, that you're waiting for someone to get infected for you to get a decision on vaccination, on vaccinating or not. So at that point in time, considering the crisis that you are in, it was more beneficial actually and more wise to actually offer vaccination for a lot of these population-based vaccination. The procedure of how the vaccination was undertaken is maybe the question that we need to question. Was it necessary for us to force people to be vaccinated? Because now, right now, because of this vaccine hesitancy issue, I think one of the biggest problems is that how we approached the entire communication strategy, and insisting that people get vaccinated, forcing them.
Yeah.
I think that is where, to be honest, I think there should be much more improvement in that sector. But vaccination indeed was important, but I think we should have been a bit more structured.
Was there a role for booster vaccines?
So yes, so currently for the healthy population, that is definitely, those are the questions that we really need to answer, particularly for the healthy population. Right now, because right now I'm writing, I'm in a panel that we actually developing guidelines for how we vaccinate immunocompromised patients, so patients with very weak immune systems. And from the evidence, particularly for COVID, even four boosters alone are not enough.
Or not?
Are not enough
Okay.
to get them to
The level that is needed.
to the level that is needed. We're actually looking at the evidence, and even 4 doses are not enough. In fact, their baseline is 3 doses. Then you start boosting. So for us who are getting like a primary of 2 doses, because me, I got the AstraZeneca, which was a primary of 2. Then you get boosted with an mRNA, because I was boosted with a Pfizer dose. But you find that now for the immunocompromised, they actually have to be, their primary series has to be fully mRNA.
Okay.
Yeah, has to be fully mRNA. And even with that mRNA, you find that like after 6 months, the antibodies still start
Showing up.
coming down. So you have to keep boosting. Yeah. So for them, you actually have to have a primary series of 3 doses, then start boosting from the 4th dose. So for them, there is already a clear indication that they need to keep being boosted. But for the healthy population, I think after the 3 doses, it's not clear whether I need a 4th dose or a 5th dose. That is still not it's still not very clear. But for the people with weak immune systems and the elderly,
Yeah.
there still seems to be some evidence that they might still benefit from boosting.
Interesting.
Yeah.
Then, when we come to the vaccines themselves, there was a number of rising inaccuracies or myths, and even clinical conditions that were showing up after the vaccination, where you'd notice people have chest issues, clotting issues. Was this supposed to be an expected thing before the vaccination campaign was massively forced on everyone's throats?
So one of the challenges that we have with, for example, clinical trials is that particularly, remember, a lot of the clinical trials that were done during COVID were really
Pushed.
pushed. Yeah, so you'd merge multiple phases. So you'll find that the way we go sequentially, you do a phase 1 where you are looking at safety, and then you do a phase 2 where you are looking at still safety, but a bit of how the vaccine is performing. And then number 3, your phase 3, where you look at a lot of how the vaccine is generating protection, and then a bit of some minimal safety issues. So you find that a lot of these were being combined. So you combine particularly your phase, some vaccines, the studies were combining both phase 1 and phase 2. So you are looking at safety majorly, and also how the vaccine is performing majorly at that point. Or you do a phase 2 and phase 3 where you're looking more at how the vaccine is performing in the real world. Is it preventing you from getting an infection? And then safety is also being assessed, but you're not assessing it to the level of the population. And that happens with all clinical trials. So in essence, what that means is that there are a lot of trade-offs that take place. So some safety signals may not come out, like what is now coming out when it's now being applied, in a very wide population. Because remember, in clinical trials, you're probably looking at a few tens of thousands of patients, maybe about 30 to 33,000, where you might not see such safety signals coming out. And now when you're vaccinating like 1 million or 2 million, then you
the
find
numbers start showing up.
then now you start seeing now some of those safety signals now start originating. So you find like now in about 2 million, you're finding like 3 to 5 cases of people clotting now start coming up. And I know it is not because that those are cases which I think still need a bit more thorough investigation into why some patients are clotting while others are not clotting. Because when you still look, it's still a minority of patients who are
Having
clotting,
those
who are having those.
complications, yeah.
Yeah. So it is good to actually investigate why some of these patients are having some of those adverse events. But of course, with every vaccine, there must be some,
Kind of mild disease process that will
some
come
mild,
in.
yeah. So that's why the phase four studies are very important, because phase four is more of your pharmacovigilance.
Yeah.
So you're assessing how that product is performing in the real world, and then you report some of these cases, and those cases are actively investigated. But personally, I would not condemn the entire process.
Interesting. Coming on from vaccines again, we noticed there has been a lot of myths that surround vaccines, and there are individuals who identify as anti-vaxxers, that they will not allow their children to either get the BCG or polio or whatever vaccine. What would you tell them with regards to the COVID?
Having been in the vaccine field for a while, because I work with a lot of vaccines, I think one of the things that I have come to realize, if this were me in 2019, I would have rubbished off this guy. I would have rubbished them off. You're like, you're spreading myths, and but nowadays I take time to actually listen and see where exactly
Yeah.
is this myth coming from
Yeah.
before we condemn them.
Uh-huh.
In my clinic, what happens is that for any vaccine, not just COVID, but for any vaccine, we actually have a discussion with the person who is coming in to be vaccinated. We actually have a thorough discussion on why this vaccine is being given, what are the anticipated benefits, but also what are the anticipated possible adverse events. We did not do as much of that during COVID. That one I must admit. We didn't take time to thoroughly explain. I think I think a lot of excuses can come out that maybe we're in an emergency, which is true. We are really in an emergency. But normally for a vaccine process, you have to explain every single process and actually consent these patients to actually receive this vaccine. So coming to COVID, if I'm in an active outbreak situation, or if certain cases come up, and you are immunocompromised, that one I would definitely, have a very long discussion with you, and convince you towards getting vaccinated. And the reason is because we've actually seen for immunocompromised patients, for people with very weak immune systems, the benefit is way much higher than you getting the actual infection itself. Because when you get the infection, it's more or less you do not have something to protect you. So you're basically just affected. But that is something you have to discuss with you properly and actually allow you to make that decision. But would heavily weigh towards allowing you towards getting vaccinated. If you are the so-called anti-vaxxers, nowadays I'm really against that terminology.
Why?
Because some of these patients who talk to them, they actually have valid concerns. Some of them, when they read, you read certain things and you are like, oh, by the way, there's this, and yeah. So for me personally, it will be like, instead of giving them these names like, anti-vaxxers, vaccine skeptics.
Yeah.
I think sometimes would look for a lot more friendlier term, like people who are unsure, or people who are uncomfortable. And so it is our work as healthcare providers to make them comfortable about, rather than condemning them, you just make them comfortable and actually have a discussion with them and listen to their concerns. But having said that, there are people who are already wired, even however much you explain they are completely wired that they would never get vaccinated. They'll never get, they'll never receive some of these vaccines. And the problem is that with some of these patients is that with that conviction, they spread that conviction to their other
Families,
families,
colleagues.
friends, and that is where the problem now comes in. But particularly for COVID, for immunocompromised individuals, it is just a matter of a discussion, a discussion, helping them to understand and also
Yeah, 5 minutes.
and also for acceptance. Yeah.
Okay.
So that really would be my approach to this, but really emphasized that the vaccine is safe. Really.
Perfect. We have a few minutes left, and I think this would be the last question. Do you think that COVID-19 was the least of the worst that we should expect, in the sense that COVID-19 was just like a rehearsal?
Well, right now we are living in a world of intense globalization. People are traveling a lot. There's a lot of global boiling, as the UN Secretary General puts it.
Yeah.
There's a lot of human-wildlife interaction. So definitely we've not had the last of pandemics. Because in fact, most of the pandemics, more or less, will come from two sources. Number one, from our human-animal interaction, and number two, from global boiling.
Okay.
Because as global boiling happens, there are a lot more vectors that come up, and these vectors move around.
Well, what's global boiling in simple words?
So global boiling is whereby what people are calling global warming,
Okay.
whereby as as the climate warms up, it creates a very conducive environment for certain vectors, for example mosquitoes, to start thriving, for certain ticks to start thriving. So that's why you find in some places you find like there are things like tick-borne infections like
diseases,
tick-borne encephalitis. In the coast region, there are things like dengue, chikungunya, which are becoming a bit of a problem there. In places like Kisumu, where dengue was unheard of, now we are seeing cases coming from there. In Kajiado County, where there was no dengue, cases are coming from there. So really, very clustered epidemics coming from such areas. And then we've come to places now like where there's a lot of this human-wildlife conflict. Human-animal interaction.
Yeah.
You find like in the US the problems with H5N1 influenza,
Yeah.
which is purely from animals. So really, we've not had the last of this.
Not had the last. I think we've come to the end, Dr. Hari. Honestly, appreciate your insight. I've learned a lot, and I hope that the community has also learned something about COVID and what to expect, hopefully in the near future. And what's your final words you could tell our community?
Well, one of the things that I will tell our community is that number one, we should not. These bugs are part of us. I think the only thing is that we need to make sure that we find a way of making sure that these bugs do not affect us in the wrong way. So just making sure that we continue maintaining our hygiene, we continue, washing our hands, but more importantly, for those infections that are vaccine preventable, we try as much as possible to get vaccines for them.
Perfect. Thank you, Doc, once again. If you guys have any questions, any comments that you want to let us know, please engage with us as well. Do the thing, subscribe, share these conversations, because I think it would help people, as well as like and subscribe. Laughing Love Good. Peace out.